Yeah, okay, okay.
Good evening, everyone. This topic is about intraventricular hemorrhage. We'll be looking into the um, incidence, neuropathology, pathogenesis, clinical presentation, complications, diagnosis and grades of severity, management, and prognosis. So, as we all know, the most common variety of neonatal intracranial hemorrhage is intraventricular hemorrhage, which occurs in 15 to 25% of very low birth weight newborns. And with grade 3 IVH and periventricular hemorrhagic infarction, which is a severe type, occurring in 16% of very low birth weight neonates. And over the past 2 decades, there has been a gradual decline in incidence from 40 to 60% to 15 to 20% currently. But due to the increased survival of very low birth weight infants, we observe an increased absolute number of infants with IVH still. And in term newborns, it has been observed to be 4.6% of incidence. And the site of hemorrhage, as we all know, is the germinal matrix, which is a highly cellular gelatinous texture and richly vascularized area, which is located immediately ventrolateral to the lateral ventricle. And the main thing is that this area contains precursor cells, both for the cerebral excitatory neurons and the neuroglial precursors, including the cerebral oligodendroglaya, astrocytes, and the late migrating GABAergic neurons. So as you can see here, here is a lateral ventricle and lined by ependymal layer, and this is the caudate nucleus. And subependymal, you can see the germinal matrix. This area is richly vascularized and has the neuronal precursors. And coming to the vascular supply, the arterial supply of the germinal matrix is mainly by anterior carotid artery from the internal carotid artery, striate branches of middle cerebral artery, and Huebner's artery, which is a branch of anterior cerebral artery. These arteries supply this germinal matrix, and the terminal branches form a relatively vascular end zone of vascular supply, which makes the area vulnerable to ischemia, reperfusion, injury. And venous drainage is also significant in terms of pathophysiology, where the medullary veins, choroidal veins, and the thalamostriate veins join together and form a terminal vein in the substance of the germinal matrix. And they take a U-turn and turn into the internal cerebral vein and finally into the vein of Galen. And the site of hemorrhage, this capillary blood is composed of large irregular endothelial line vessels that do not exhibit characteristics of arterioles or venules, and they are ultimately remodeled into a definite capillary bed when the germinal matrix disappears. And this area, as evidenced by elevated VEGF and angiopoietin levels, there is exuberant angiogenesis happening here. And here you can see that these vessels are large diameter with fibronectin deficient basement membrane and diminished coverage by the pericytes. And the astrocyte end feeds are also incomplete and they lack glial civilary acidic protein. So the mesenchymal support is also deficient. The site of hemorrhage has been observed. Yeah, the germinal matrix is around 2.5 mm in neonates at 23 to 24 weeks of gestation and 1.4 mm at 32 weeks of gestation, and it nearly completely involutes at 36 weeks of gestation. The most common site observed in 28 to 32 weeks neonates is a thalamus striate group at the level of the head of caudate nucleus. Here you can see the caudate and the thalamus. This is the thalamus striate group. This is the most common site observed in 28 to 32 weeks. And more than 32 weeks, the common site is just above the caudate. Coming to the pathogenesis, basically it is due to intravascular, vascular, and extravascular factors. Intravascular factors, the most common factors are the fluctuating cerebral blood flow in the background of pressure passive circulation. So the factors contributed to increased cerebral blood flow and fluctuation include hypercarbia, hypotension, even restlessness of the neonate, PDA with left to right shunt, increased FiO2, hypoglycemia, decreased hematocrit, and hypernatremia, hyperglycemia. So, and also the systemic BP has been found to be elevated in even physiological conditions like REM sleep and the first few minutes and hours after birth, and even innocuous clinical abdominal examination, handling, and with any painful stimulation. And also, while instilling pediatrics, tracheal suctioning in the event of pneumothorax and rapid evacuation of pneumothorax. And if the baby is being given rapid volume expanders or exchange transfusion, and when there is a ligation of PDA and seizure. So the basic mechanism behind this, the preterm neonate, there is lack of auto-regulation. Auto-regulation is the ability of to maintain a constant cerebral blood flow despite changes in the arterial blood pressure. So as you can see here, in adult, the auto-regulation is much well established, whereas in term neonates, the window of auto-regulation is little low, with a between map of 40 to 60. In preterm, it's almost zero. And you can also see the arterial blood pressure variation with temperature measurement when the baby goes in for apnea, and even small manipulation and feeding, suctioning. And it's also been found out that the pressure passive relationship of cerebral blood flow, which means that the changes in the mean arterial blood pressure are exactly reflected in the cerebral blood flow, as you can see here. And so this pressure passive circulation makes the preterm neonates, the cerebral vasculature, vulnerable to intraventricular hemorrhage. And the other factors, other vascular factors include increased cerebral venous pressure as occurs in difficult labor and delivery with extreme head flexion or extension when the neonate is asphyxiated, and when we are delivering high inflation pressures, tracheal suctioning and pneumothorax. And decreased cerebral blood flow as occurs in perinatal hypoxic ischemic encephalopathy, where the IVH is evident in within first 12 hours. And postnatal ischemic events like apnea, myocardial dysfunction, sepsis, bradycardia has also been associated with decreased cerebral blood flow. And it has been studied that maternal intrauterine infection and fetal systemic inflammation with elevated interleukin 6 levels contributes to reduced cerebral blood flow. And other factors include platelet and coagulation disturbances, mainly due to the high prostacyclin synthesis, which is occurring in the lungs of a preterm neonate with RDS. And mutations in coagulation factors, factor 13, 5, and 2 has also been implicated. Extensively, studies have been done, and they have been concluded that there is no independent role for maternal aspirin, and heparin flush, which is used in maintaining the patency of central lines, the results have been inconclusive. So vascular factors, as we already discussed, the vessels in the germinal matrix are basically large diameter, and with lacking mesenchymal supports, and basement membrane is also deficient, and with constant angiogenesis, which makes the zone in a relative state of hypoxia all the time. Extravascular factors, there is reduced supporting elements in terms of reduced glial fibrillary acidic protein, reduced and immature tight junction protein, zonulin, occludin, and claudin. And there is also increased fibrinolytic activity secreted wherein the immature astrocytes secrete more plasminogen, which lyses the clot, thereby making a small hemorrhage into a progressive hemorrhage. And the postnatal decrease in extravascular tissue pressure, which is physiological, also causes a transient increase in transmural intravascular extravascular pressure gradient, thereby leading to IVH. So overall, there is a phase of ischemia followed by a phase of reperfusion in the background of pressure passive circulation, which leads to initial reduced cerebral perfusion leading to cerebral ischemia when the neonate is immature with myocardial dysfunction, and when there is anemia, hypovolemia, and when there is PDA with left to right shunt, and added on by ventilatory instability with associated hypocapnia and surfactant administration. And later, it manifests with reperfusion injury with increased cerebral perfusion, with increased systolic and mean arterial blood pressure, hypercapnia, for finally ending up in IVH. So the clinical presentation, the principal clinical setting that has been observed is the preterm neonate with RDS requiring ventilation. And it has been shown that 50% of hemorrhages occur in day 1, especially within 5 hours of life. And on day 2, 25% has been observed. On day 3, 15%. So by 72 hours of life, 90% of IVH has already occurred. And prenatal IVH is possible in the setting of neonatal alloemia thrombocytopenia. 3 syndromes have been observed. The worst thing is catastrophic presentation, which occurs in minutes to hours, and where the baby goes into deep stupor, coma, throws seizure, and decerebrate posture, and presence of flaccid quadriparesis, and there will be absent dorsal side response and respiratory instability and metabolic acidosis and SIADH. This obviously reflects the movement of the blood from the lateral ventricles through the ventricular system along the midbrain pons and medulla. And the second thing is saltatory presentation, which is subtle and it evolves over many hours, where the neonate presents with altered sensory, altered level of altered neurobehavioral state and reduced motility, hypotonia, subtle eye signs with skew deviation and all. And this is stuttery course wherein the symptoms resolve for a quite some time and then reappear again. And it is like that only. And the third thing is clinically silent type, where it is too subtle that it is almost overlooked, except for an unexplained fall in hematocrit. And the consequences of this intraventricular hemorrhage has been studied extensively, and they have found that the germinal matrix is destroyed, and there is dismaturation of the cerebral white matter, cerebral gray matter, and cerebellum, as the matrix contains the neuronal precursors. And there is also one entity called periventricular hemorrhagic infarction, which we'll be discussing, and post-hemorrhagic hydrocephalus. And so the germinal matrix hemorrhage causes germinal matrix destruction, thereby leading to reduced proliferation of the precursors, thereby resulting in cerebral cortex and thalamic dismaturation. And the hemosiderin and the free iron activates the microglia, which increases reactive oxygen species, leading to oligoprogenitor cell injury, and thereby reduced in number of mature oligonucleotide cells and reduced myelination and axonal dismaturation. And the hemosiderin in the CSF, as it reaches the cerebellum, also causes loss of external granular layer, leading to cerebellar dismaturation. And periventricular hemorrhagic infarction has been observed in 10%, 10 to 15% of IVH, associated with any grade of IVH. Previously, it was thought to be grade 4. Now it is a separate entity, and is a parenchymal lesion due to hemorrhagic necrosis in the periventricular white matter, just dorsal and lateral to the external angle of lateral ventricle, where the veins form a confluence. It follows a fan-shaped distribution of the medullary veins, and it is basically here you can see the medullary veins, and this area is involved in periventricular hemorrhagic infarction. And this is strikingly asymmetrical, mostly unilateral, and has a lower predominance with parietal more than frontoparietal and temporal. And the germinal matrix hemorrhage causes periventricular venous congestion, leading to periventricular ischemia, finally ending up in hemorrhagic infarction. So the sequelae is a single large porencephalictis, as you can see here. And the next complication is progressive post-hemorrhagic hydrocephalus, which can be acute or subacute. Acute is observed over days, subacute is observed over weeks. And the acute is mainly due to particulate blood clot causing obstruction of the arachnoid villi. And there has also been observed that there is decreased plasminogen levels in CSF, thereby the clot is not lysed early. And subacute hydrocephalus is due to obliterative arachnoiditis, mainly by fibrosis due to elevated TGF and procollagen 1C peptide. So the pathogenesis behind post-hemorrhagic ventricular dilatation involves both the mechanical compression of the periventricular tissue and the alteration CSF dynamics in terms of outflow site fibrosis leading to blockage of CSF drainage, and TL4 activation and NFKB inflammatory response leading to hypersecretion of CSF, also contributing to ventricular dilatation. Word about periventricular hemorrhagic infarction versus periventricular leukomalacia. So periventricular hemorrhagic infarction, as you just now saw, it is venous circulatory disturbance, whereas PVL is mainly due to arterial, and PVHI is invariably hemorrhagic, whereas PVL is mostly ischemic in origin. And PVHI is markedly asymmetrical and unilateral mostly. PVL is bilaterally symmetrical. And the sequelae PVHI develops into a single large cyst, whereas PVL evolves into multiple small cysts, as you can see here in this picture. So coming to diagnosis, suitable screening procedure has to be adopted. The most common and the most acceptable and the gold standard is cranial ultrasound. MRI can be optional when we want to demonstrate parenchymal details of PVHI. Just a minute. Cranial ultrasound is the procedure of choice with as it has high resolution and it is portable and there is lack of ionizing radiation and relatively affordable. And the common windows include anterior fontanel, posterior fontanel, and mastoid windows. And with the coronal scan, we can identify the germinal matrix bleed. And with the parasagittal scan, we can grade it based on the hemorrhage extending into the lateral ventricular node. And
Can the others please mute their microphones?
um, so with ultrasound, we can see the germinal matrix bleed if it's present or not, and we can grade the severity based on the parasagittal view as it extends into the lateral ventricle. And the fibrin mesh within the clot is visible as dense echoes. That's what we see, and we can see all grades of IVH and BVHA and PVD. And Doppler of anterior cerebral artery is useful in planning the intervention. So time to screen, AAP guidelines is to screen all neonates less than or equal to 30 weeks within 7 to 10 days of life, and a repeat scan at 4 to 6 weeks, and a term equivalent age or a discharge. And MRA is optional. In IAP, they say if the neonate is less than between 20 to 23 to 28 weeks, the scan has to be done on day 1, preferably 6 hours, and on day 3, and at 1 week of life and 4 weeks of life and the term equivalent age. If the neonate is between 28 to 31 plus 6 weeks or very low birth weight with life support, this screening recommended is on day 1, preferably within 6 hours, and day 3, and after 1 week and 4 weeks and term equivalent age. If the neonate is not requiring any life support, the recommended screening protocol is on day 3 to 1 week and at 4 weeks and at term equivalent age. And if the neonate is at between 32 to 36 weeks with risk factors for IVH, then the routine screening include on day 3 to 1 week and term equivalent age. In CMC, we follow screening for all babies less than equal to 32 weeks or very low birth weight on day 4, day 10, and day 28, and at term equivalent age. So it has been observed that the progression of IVH occurs in 20 to 40%, with maximum extent attained by 3 to 5 days of initial diagnosis. So a second scan has to be repeated after 5 days. The Canadian Pediatric Society recommends a repeat ultrasound 7 to 10 days later in case of a grade 2 or higher IVH, or if there is any white matter injury. And weekly ultrasound is recommended if ventricular dilatation or worsening IVH is detected. And IAP recommends alternate day ultrasound in the first week after diagnosis and at 2 weeks of life for a preterm or full-term infant with IVH. So coming to grading, there are two systems. The older one was PAPL criteria, which was basically for CT-based imaging, and which has been extrapolated to all ultrasound also. The latest one is the Volpe criteria, which is mainly for ultrasound guided thing. So in Volpe's criteria, we have grade 1, grade 2, grade 3, and PVHI. Grade 1 is the blood in germinal matrix with or without IVH occupying less than 10% of the ventricular cavity. Grade 2 occupies 10 to 50%, as you can see here. And grade 3 is more than 50% without ventricular dilatation. And periventricular hemorrhagic infarction is, as you can see here, is a separate notation located in the angle of the lateral ventricle. And this is one picture where it has evolved finally into a porencephalic cyst. So with ultrasound, we can also assess if there is post-hemorrhagic ventricular dilatation by certain indices. The first thing is ventricular index or Levin index, which is the distance between the midline and the lateral border of the anterior horn of the lateral ventricle. It's measured in the coronal view at the level of the foramen of Monro. If it is more than 4 mm above the 97th percentile, it has to be, it needs intervention. And the anterior horn width is the distance between the medial wall and the floor of the lateral ventricle, measured at the widest point of the anterior horn of the lateral ventricles in the coronal view at the level of foramen of Monro. If it is more than 4 mm or more than 1 mm more than 97 centile, intervention has to be done. And thalamo-occipital distance is a distance from the outermost part of the thalamus, it is junction with the choroid plexus uh, to the outermost part of the occipital horn, posteriorly to the parasagittal view. So this is important because the occipital horns are dilated to a greater extent initially than the frontal horns, and it can be sometimes it can be the only site of ventricular dilatation. And if it is more than 26 mm or more than 1 mm more than 97 centile, intervention is recommended. And coming to the management part, IVH cannot be treated as such. It can be prevented only by perinatal and postnatal interventions. And if occurs, we can prevent the progression of hemorrhage and screen for progression and treat the complications like post-hemorrhagic ventricular dilatation. So it has been studied in a recent meta-analysis where the anterior corticosteroids, indomethacin prophylaxis, volume targeted ventilation, early erythropoiesis stimulating agents have been found to be uh, favorable in reducing the incidence of severe IVH in preterm neonates, as you can see here. Tocolysis has also been found to be significant in the study done at, in the study that is the EpiPage 2 study. The secondary outcome they observed was death under or grade 3-4 IVH. It was found to be significantly lower in preterm infants with tocolytic exposure compared to those without, with a risk ratio of 0.78 with the confidence interval 95%, 0.60 to 0.98. And nursing interventions like maintaining the head in the midline, tilting the head of the incubator, head end of the incubator 50 to 30 degree, avoidance of flushing and rapid withdrawal of blood, and avoidance of sudden elevation of the legs has been studied. And it has been observed that they are associated with lower risk of developing intraventricular hemorrhage of any degree and cystic PVL and oral mortality also, with adjusted odds ratio of 0.42 with 95% confidence interval of 0.27 to 0.65. So the other interventions which can be helpful in preventing IVH, the main thing is to prevent preterm delivery and in utero transport of the neonate, as it has been observed that transport within 48 hours of life with more than 60 minutes have been associated with higher odds of severe IVH. And mode of delivery, it has been observed that cesarean section is better than normal vaginal delivery in preventing IVH. And temperature stabilization is important as there are higher odds of severe IVH with moderate hypothermia in the neonate. And resuscitation at birth has to be done meticulously with avoiding hypoxemia, hypercapnia, and high inflation pressure, high PEEP, and avoidance of bicarbonate infusions. These have not been evidence-based. These are just interventions which are supportive to prevent IVH. And intubation by an experienced caregiver, as it has been observed that more than 3 attempts in first 4 days, there is 28 times more likely to develop severe IVH. And fluctuating cerebral blood flow velocity has to be tackled with sedatives and synchronized ventilation. And regional cerebral saturation has to be maintained within 55 to 85%. And cerebral blood flow has to be maintained in normotensive or in a permissive hypotensive range, where the neonate is clinically well perfused with BP recordings around in the lower end. And prompt treatment of microbial dysfunction with boluses with inotropes is required. And correcting coagulation abnormalities, if any, can also help. So acute treatment is mainly to maintain the cerebral perfusion with boluses and inotropes, and preventing further progression of bleed by taking care of sugars, electrolytes, positioning, and other things, and treating overt seizures vigorously in the setting of IVH. And in case of post-hemorrhagic ventricular dilatation, if there is a raised ICP, we can go for serial lumbar puncture, external ventricular drain, PP shunt, or drift, which is drainage irrigation fibrinolytic therapy, where they inject tissue plasminogen activator inside, and external third ventriculostomy, and finally choroid plexus ablation can also be tried. Serial neurosonograms are mandatory to assess ventricular size, and as the classical clinical signs of evolving hydrocephalus or apparent only after days to weeks. And minimum 2 ultrasounds per week to monitor development of PVD is followed universally. Prognosis, short-term prognosis has been studied in terms of mortality and progressive ventricular dilatation. As expected, you can see in based on the weight and the grade, weight of the neonate at birth and the grade of IVH, the severity is increasing. Long-term outcome has been studied in terms of spastic motor deficits and cognitive deficits, with PVHI being the major determinant of spastic deficit. It has been also studied, school age outcome has also been studied, where they found that 290 preterm babies with less than 1000 grams at birth, they have been followed up at 8 years, where the CP rates have been 6.7%, 6.4%, and 24%, with no IVH, grade 1 IVH, and grade 2 IVH. So even grade 2 is associated with the higher rate of cognitive deficit. And a PPH study showed that the greater severity of IVH is associated with increased risk of adverse neurodevelopmental outcome, as you can see here. Outcome of periventricular hemorrhagic infarction is based on the site of involvement. If it is a parietal, it has been associated with bilateral spastic cerebral palsy and unilateral spastic cerebral palsy. If it is a frontal or temporal, it's mostly associated with cognitive, behavioral, and visual problems. A few lines about IVH in term units. Common site of origin observed is in choroid plexus, followed by thalamochoric group, as it is a last area of germinal matrix to involute, and followed by subependymal germinal matrix and periventricular cerebral parenchyma. So the pathogenesis involves mainly trauma due to difficult delivery or instrumental delivery, and followed by coagulation disturbances. Clinical features are almost the same, with irritability, stupor, apnea, seizures, fever, bulging AF, and jitteriness, and ending up in hydrocephalus later. Diagnosis, apart from ultrasound, MRI and MRI MRV can be helpful because it is primarily vascular radiology. And the prognosis, so if it's involving thalamus, it has been observed with a worse outcome. As expected, neurological deficits in hydrocephalus and death have been observed. So the take-home measures, just preventive measures has to be adopted meticulously, and strict adherence to screening protocol is recommended. And if it occurs, prognosticate the neonate, and better quality of life by early stimulation can be done. Thank you.
Nandhini, can you just recollect again the evidence-based strategies alone, okay, for prevention of IVH?
Yes, sir.
You can tell, it's okay, no need to display the slides.
So, in the recent meta-analysis, it has been found that antireal corticosteroids, indomethacin prophylaxis, volume-targeted ventilation, early erythropoiesis-stimulating agents, and prophylactic ethanol select has been found to be significant in reducing the incidence of severe IVH in preterm neonates. Here you can see there is difference for each of them. And tocolysis has also been studied in EpiPage study with significantly lower uh, grades of lower incidence of grades of severe grades of IVS, grade 3, grade 4, in infants with tocolytic exposure with relative risk ratio of 0.78 and confidence interval of 0.60 to 0.98. And nursing interventions has been recently concluded that maintaining the head in the midline, tilting the head of the incubator 50 to 30 degree, and avoidance of flushing and rapid withdrawal of blood, and avoidance of sudden elevation of the legs has been associated with lower risk of developing IVH and also cystic PVR and mortality. There are a few other interventions like in nursing interventions that change in position has to be only every 6 hourly, and at least two members has to be involved in when the neonate is being when the position is being changed.